So our case study is on Donald Foster, who's a 68-year-old male. He presented to ED with shortness of breath, discomfort around his neck and shoulders, diaphoresis, and chest pain. He says that he first experienced these episodes of chest pain 4 months ago when he was carrying out repair work on his car. Since then, he has had more recurring episodes, which have been longer and more persistent. And the latest one being when he was in bed watching TV and eating dinner. Um, He says that resting and sleeping don't relieve the pain, and neither do his medications that he was prescribed by his doctor. On his family's side, his mother has chronic hypertension, and his father died at 62 from a heart attack. So 6 months ago, his local doctor diagnosed him with high blood pressure and high cholesterol. He's currently on 50 milligrams of atenolol daily for hypertension and 50 milligrams of Simvastatin for cholesterol. Donald lives by himself. His wife passed away 1 year ago. His son is 38 who lives interstate and visits irregularly. His son states that since the passing of his wife, Donald has been eating a lot of fast food, gaining weight, and drinking a lot more and smoking a lot more. He sees his work colleagues once in a while at the bar, and he has been unemployed for 3 months due to a loss of license, and he smokes 2 packets a day.
Right. Unstable angina. So unstable angina is an acute coronary syndrome, and that is caused by unexpected chest pain, usually while at rest. And this is due to the imbalances in myocardial oxygen supply and demand. This is because fat deposits and plaques, known as arteriosclerosis, is reducing the blood flow to the heart muscles. Further, if any ruptures occur, the plaques have further complications to the coronary vessels, therefore reducing and blocking more blood flow. Right, now I'm going to discuss the differences between stable and unstable angina. Stable angina is very predictable and it has patterns. So the onset of stable angina is pretty much anything to do with exertion or physical activity or stress. On the other hand, unstable angina is really unpredictable and unexpected. The onset of unstable angina could be at rest, could be at sleep, could be with little physical exertion or stress. It could happen at any time. Therefore, this is very dangerous and is a clinical emergency. The pathophysiology between stable and unstable angina is pretty much similar, but there's a little addition to unstable angina. Stable angina is when the plaque forms and decreases blood flow to the myocardium, and then therefore there will be myocardium ischemia, therefore there will be chest pain. Unstable angina do have the same first symptoms or the first pathophysiology of that, but also includes the rupture of the plaque where the platelets will aggregate and thrombosis of the vessel will begin, further restricting the blood flow to the heart, and then there'll be that sudden pain. If that further arises, there'll be myocardial infarction or sudden death. Yep, so with unstable angina, there's two parts of it. So there's the formation of arteriosclerosis, and there's also the rupture of the plaque or the arteriosclerosis. Arteriosclerosis is categorized or defined as soft deposits of fats and fibrins that hardens over time, and this stems from the inflammation response of the injured endothelial cells that actually lines the arteries and its walls. Risk factors that causes or contributes to endothelial injury are smoking, hypertension, nutrition, and increase in age. So smoking 2 packs a day constricts the blood vessels and also increase the low density lipoproteins, so LDLs. Therefore, that will wears off the heart muscles and cells. With the history of hypertension, it also wears over muscle cells over time and also produce that inflammatory and that injury to the endothelial cells. Poor nutrition, eating fast food all the time, contributes to hypercholesterolemia and dyslipidemia, which facilitates to LDL cholesterol buildup on the arterial walls. With the increase in age, so Donald is a 68-year-old patient, decreases in collagen fibers and elastin. Therefore, that decreases in arterial stretch and elasticity, therefore decreases in the blood vessel compliancy. Right, moving on, we're going to talk about the pathophysiology of the arteriosclerosis. Now, atherosclerosis is the inflammation of the endothelial cells. Now, that inhibits the normal production of antithrombics and vasodilating factors. Therefore, the endothelium is unable to prevent clots or vasodilate effectively. Undesirable factors of the endothelium that contributes to vasoconstriction is the secretion of serotonin, endothelin, and noradrenaline. Also, angiotensin converting enzymes, so ACE, the ACE, in the endothelium converts angiotensin 1 to angiotensin 2, also contributes to vasoconstriction. Now, these factors here, vasoconstricting factors, further decrease blood flow through the coronary arteries, dominating vasodilation. This also contributes to myocardial ischemia. Continuing on with atherosclerosis, the injured endothelial cell allows monocytes plus other immune cells to adhere to the endothelium. Now, this releases different kind of inflammatory cytokines, furthering injuring vessels. The inflammation process causes toxic oxygen, so it causes oxidation. Therefore, when LDLs travels through the vessels, it is oxidized and engulfed by the macrophages, which then penetrates through the intermedia of the vessel and of the artery and forms foam cells, and then it gets enlarged. The large accumulation of these foam cells forms a lesion, and it's called a fatty streak, further restricting the blood flow through the artery. So you have a normal artery here, and you got the one that is formed and it's restricting the blood flow. Right, so moving on to the pathophysiology of unstable angina. So this is the second part where the atherosclerotic plaque increase in size. When it increases in size, there might be a rupture occurring or an ulceration. When rupture or ulceration occur, the platelets will aggregate and bind to that site, causing more restriction to blood flow. And this will cause myocardial ischemia. The thrombus causes either a partial or a full occlusion of the actual artery, while at the same time vasoconstrictions occur. Normally the episode of a unstable angina will last for about 10-20 minutes until normal perfusion returns. If normal perfusion doesn't return, myocardial necrosis will occur. During a prolonged occlusion, myocardial infarctions may occur or sudden death. So that's the worst of the worst case that might happen. Continuing with the patho, pain response is due to a large buildup of lactic acid or abnormal demand and stretch on the myocardium, now which provokes the nerve fibers and irritates it. The pain can radiate from the chest to the shoulders, the neck, and the jaw. Pain felt is another way of the heart conveying that it needs oxygen or it lacks oxygen. Respiratory distress occurs due to the lack of oxygen and blood flow in the circulation. Therefore, the body increases the work of breath, including shortness of breath, as a compensatory mechanism to reverse the hypoxia. Continue on, diaphoresis occurs due to the sympathetic nervous system response to pain, therefore, an increase in blood pressure. Therefore, it releases the hormone acetylcholine. This is a compensatory mechanism to relieve pain as well as an attempt to lower blood pressure.
So in regards to Donald's nursing management, we would be working with the doctor in charge and the coronary ward. This is to get a diagnosis and treatment care plan as fast as possible. And we would also work with his family to get an accurate history and to let them know ways that they can help Donald. So there are a few major goals we would to do with his nursing. The first one being the immediate treatment and prevention of angina when it occurs. So when he's experiencing angina, we want him to stop anything he's doing at all, and we want him to sit or rest in the bed in a semi-Fowler's position. This is when they're laying prone on their back and their head is elevated 30 degrees. We would also administer nitroglycerin. Nitroglycerin reduces the myocardial oxygen consumption, and it enhances oxygen delivery. And we would want to do this up to a maximum of 3 times. We also want to check his vital signs every 5 minutes. This is to make sure he's not deteriorating and to check the effectiveness of the medicine. And we also want to document the effectiveness of the drugs. If his oxygen sats are below 93%, we want to give him oxygen therapy. This would be 46 liters through a Hudson mask. We would also give him aspirin and any other pain relief that he's charted for. And then we would notify the nurse in charge and the medical team. And it's also likely that he would be on a cardiac monitoring when he first enters the hospital and throughout his stay. Another goal would be patient education. This is when we would provide information to him about his condition, the disease process, and his treatment. We want him to know what to do when he's having an angina attack. And to do this, we'll give him a written action plan for his chest pain and how to use his prescribed drugs, such as his GTN spray, when he's having an attack. Another goal would be to make sure he adheres to his self-care program and to prevent complications. We want to work with Donald to figure out activities that cause him angina and to plan around it. And we also want to make sure he comes in for regular follow-up monitoring for his condition. And this would be getting some follow-up ECGs and blood tests. Another goal would be lifestyle changes. We want to encourage Donald to stop smoking and to eat a healthier diet. So this would be more fruit and vegetables and to limit his salt and unhealthy fat intake. And this is to help with his pathophysiology. Some additional nursing interventions would be pain assessment. We would do this on his admission and during and after his angina attacks. And the reason why we would do this is to assess his chest pain and if there's any progression and the effectiveness of the treatment we are giving him. This is because an unstable angina tends to increase in frequency and severity, and the way we would do the pain assessment is maybe the pain scale or the PQRST mnemonic. So we would ask him questions such as the location of the pain, the characteristic of the pain, the scale of the pain, the cause of the pain, and anything he does to relieve the pain and any other symptoms that occur alongside the pain. Another intervention would be the ECG test. So the ECG gives an electrical recording of the activity of the heart, and it's done by placing 10 electrodes on the patient's limb and chest. And the reason why we would do this is to obtain a baseline ECG and to possibly diagnose angina pectoris. We would do this on his admission for his chest pain and regular intervals throughout his stay and after his discharge from the hospital. Potential problems that could come up with the ECG is incorrect placement, not removing his clothing, and placing the electrodes wrong, and maybe any tremors and movement during the ECG test. And finally, another diagnostic test we will do is blood tests. And so blood tests would be looking at cardiac biomarkers that detect heart damage. And the reason why we would do this is because biomarkers tend to show up in the blood after the heart has been under stress and isn't getting enough oxygen. The most important cardiac biomarker tests to diagnose heart attacks are troponin. Troponin is elevated within a few hours of heart damage and remains elevated for up to 2 weeks. And rising levels of troponin tests would diagnose a heart attack. Another one would be creatine kinase. Creatine kinase is normally found in the heart muscle, and it rises when there is damage to the heart muscle cells. And finally, another one would be the blood urea nitrogen test. And the reason why we would do this is because heart failure tends to make the blood urea nitrogen result higher.
A medication that would be administered for this particular patient would be glycerol trinitrate. Due to the patient's presenting condition, GTN will help with the treatment of his chest pain or acute angina. GTN will also assist with the prophylaxis of angina that he may experience in the future. GTN will also assist in preventing acute heart failure associated with unstable angina and myocardial infarction. If a surgical procedure such as a coronary angioplasty or a coronary artery bypass is necessary, GTN can be used to produce controlled hypertension. Glycerol trinitrate is rapidly absorbed, metabolized in the liver, and excreted in urine. And its actions include the relaxation of vascular smooth muscles, decreasing venous return and arterial blood pressure, and reducing left ventricular workload as well as decreasing myocardial oxygen consumption. Its adverse effects includes headaches, dizziness, tachycardia, undesirable hypertension, nausea and vomiting, sweating, flushing, and rash. Contraindications of GTN include allergies, raised intracranial pressure, and severe anemia. Precautions that need to be noted prior to the administration of GTN include renal or hepatic disease, hypertension, hypovolemia, conditions that limit cardiac output, and current medications that lower blood pressure. In this case, the patient is using atenolol. Drug-to-drug interactions include the use of aspirin, non-steroidal anti-inflammatory drugs, and blood pressure medications. Things that need to be monitored prior to the prescription and administration of GTN include a red blood cell count as to ensure the patient is not anemic. If the patient is going to be taking heparin, which is an anticoagulant, vital signs need to be monitored and adjusted accordingly as its effects are reduced when administered with GTN. It is vital to monitor blood pressure to avoid severe hypertension and to monitor for tachycardia. Pain levels should be monitored as to determine whether the medication is effective. Monitor blood pressure to avoid severe hypertension and to monitor for tachycardia. Pain levels should be monitored as to determine whether the medication is effective. With the presenting patient being diagnosed with hypercholesterolemia, aspirin will help with the prevention of atherosclerosis due to its antiplatelet and anti-clotting properties. The indications for aspirin include acute coronary syndrome, history of symptomatic atherosclerosis, relief of pain, inflammation, and fever. Aspirin will be taken orally, metabolized in the liver, and excreted in urine. And its action is that it irreversibly inhibits platelet cyclooxygenase, thereby abolishing the ability of platelets to aggregate. Adverse effects of aspirin include cardiovascular collapse, nausea, heartburn, epigastric discomfort, GI irritation and bleeding, dizziness, and increased bleeding time. Contraindications include allergy to aspirin or non-steroidal anti-inflammatory drugs, aspirin-sensitive asthma, and severe active bleeding. Precautions that need to be considered with the administration of aspirin include the risk of bleeding, spinal injection or puncture, as to avoid epidural hematoma causing paralysis, and surgery. Using apixaban with aspirin may increase the risk of bleeding, including severe and sometimes fatal hemorrhage. Combining with enoxaparin can increase the risk of bleeding complications. Leflunomide may cause liver damage, and taking it with other medications that can also affect the liver, such as aspirin, may increase that risk. With the administration of aspirin, it is important to ensure the enterocoded medications are not crushed, as it can cause stomach upset. Patients should be monitored for GI upset and/or bleeding. Due to the excessive consumption of alcohol, the patient needs to be monitored for possible damage to hepatic function, and an alcohol withdrawal scale should be completed. Due to the patient's excessive smoking habits, it is also important to monitor for respiratory distress. Due to the excessive consumption of alcohol, the patient needs to be monitored for possible damage to hepatic function, and an alcohol withdrawal scale should be completed. Due to the patient's excessive smoking habits, it is also important to monitor for respiratory distress. Atenolol is a beta blocker and is indicated by the hypertension and angina that the patient presents with. The anti-anginal effect of atenolol is the decrease in left ventricular contractility and decreased oxygen requirements caused by a decrease in heart rate and force of contractility. The antihypertensive effect of atenolol is a reduction in cardiac output. Atenolol has become a widely used beta blocker in Australia because of its relatively long half-life of 6 to 9 hours compared to that of metoprolol, which is only 3 hours. This makes it easier with once daily administration. Atenolol is metabolized in the liver and excreted in urine. Adverse effects of atenolol are bradycardia, hypertension, nausea, diarrhea, fatigue, dyspnea, dizziness, and abnormal vision. Contraindications include bradycardia, hypertension, COPD, and asthma. Precautions that need to be considered before the administration of atenolol is if the patient has COPD or asthma, as atenolol will be unsuitable. Beta blockers decrease the heart rate, contractility, and conduction, so the administration of other drugs that produce the same or similar effect can increase the risk of hypertension and bradycardia. Beta blockers will reduce the effect of drugs acting on beta receptors such as salbutamol and adrenaline, and can precipitate asthma. Using atenolol and diltiazem together may lead to increased side effects.